So good afternoon and welcome to this month's ALS Learning Hour. I'm Sherry Mathis with the ALS Association. And before we get our speaker started today, I just want to offer a few reminders. You can add questions within the chat or the Q&A feature at any time during the speaker's presentation today. And then we'll address as many questions as possible with our time together. This presentation is being recorded and will be sent to those who registered yet later this week. So, and as usual, when you leave the webinar today, you'll receive a 4-question survey will pop up, and your feedback really matters to us. So we appreciate when you take the time to fill that quick survey out. We plan our future presentations based on some of the feedback that we receive. So, and with that, let me go ahead and get started. So today, our speaker is Tomi Toler, and Tomi is a certified genetic counselor with Washington University School of Medicine in St. Louis. And she's the associate director of the program in genetic counseling. That's a graduate program that trains future genetic counselors. She is also the lead genetic counselor with the Division of Genetics and Genomic Medicine. Tomi has been a genetic counselor for 15 years and currently sees patients with ALS in the Neuromuscular Disease Center at WashU. So welcome, Tomi, and thank you for being here today.
Thank you. Thank you for everybody that is here. Feel free to ask questions as I go along. I also have some time at the end to ask questions. Just as a heads up, when I get on my computer, my cat likes to walk across, and she's already jumped up here to see what's happening. So you may see my cat. And I'm working from home, like I was telling Sherry, in the middle of cicadas. So I'm glad that you can't hear them, but they are so loud I can hear them through my windows with my doors closed. So quite loud. Just a few important disclosures that I wanted to mention. So I am a genetic counselor on the Biogen tofersen clinical trial here at WashU in St. Louis. And then I can't provide any sort of personalized medical recommendations during the presentation, but I'll have some contact information at the end if you have some additional questions. So I thought I would start by just giving a little bit of a background about me. So I am the associate director for the program in genetic counseling. So like Sherry was saying, we are a master's degree program here at WashU in St. Louis that trains future genetic counselors. I'm the lead genetic counselor in the Division of Genetics and Genomic Medicine, and we have 10 genetic counselors in our group and see children and adults. And then, like I said, I'm currently involved in the clinical trial with Dr. Buccelli here at WashU. So I do provide pre-test and post-test genetic counseling for adult onset neurological conditions. In addition to ALS, I also see patients with family history of Alzheimer's disease or personal or family history of Parkinson's disease, kind of a wide variety, but this talk obviously will focus more on ALS. So a little bit more about me. So I'm originally from Missouri. I went to University of Missouri for my undergrad, or Mizzou. And then I went to the University of North Carolina at Greensboro for my graduate degree in genetic counseling. Being from the Midwest, I just kind of wanted to experience something new. And so then I moved to Boston, and I got to work directly with the students in Boston at the programs that are listed here, the genetic counseling programs. And that's kind of why I also involved in teaching now at WashU. I really like working with students. And I was in Boston for about 6 years before I relocated back to Missouri, working for WashU in St. Louis. I've spent about 14 years of my career doing general genetics with both kids and adults. So I've seen a wide variety of genetic conditions, not just neurological conditions, throughout my career. And up until about 2 years ago, I was actually seeing patients pretty much full time, but that now has gone down a little bit, and that's why I'm able to focus only on neurological disease. And then to make my life even busier than it was before, I am currently getting a Doctor of Public Health degree at Tulane University online, and I've been doing it since 2022. So I'm set to graduate finally next year, and hopefully I'll be done with going to school myself, but I'm hoping that what I learn in that program will help me with patients and kind of training future genetic counselors. So I thought I would start just by going over what genetic counselors are. And when I met with the ALS Association to talk about what we were going to kind of review, I thought it would be good to kind of tell you who we are and what we have been trained to do, because I think that would be very helpful. So the National Society of Genetic Counselors is our professional society. And so they provide some very specific definitions, but I'll kind of elaborate on them a little bit. So we have advanced training in medical genetics and counseling, and my job is to guide and support you through the decision-making process of getting genetic testing, helping to understand genetic testing, and also just kind of talking through what this might mean for you and your family as a whole. Genetic counselors can be specialized in prenatal genetics, pediatrics, oncology, neurology, ophthalmology, psychiatry, and many other areas. We have some genetic counselors in our group that see patients in an immunology clinic. They sometimes see patients in a lung disease clinic. So it's a wide variety of areas that we could be in. However, genetic counselors all have that training, that basic training, and then they kind of get specialized after they graduate. So I can meet with individuals or families before or after genetic testing. Here in our clinic at WashU, I don't typically meet with people before they've had genetic testing. There are just too many. So what happens is the neurologists that see our patients with ALS will order the genetic testing first. And then based on the test results, I would see them afterwards, whether or not they need additional testing or just to talk about the positive test results that they've gotten. Many genetic counselors now, one of the good things to come out of COVID is that I can actually see patients via telehealth. So I see more than 50% of the patients all essentially by Zoom like this, rather than requiring them to come in person to clinic. It's made it a lot easier for patients and families to get the care that they need. And as an aside, I am legally able to see patients in Illinois, Missouri, or Arkansas, and that's based on licensure laws and things like that. So I have some information at the end, which is if you wanted to see a genetic counselor and you weren't in those 3 states or wanted to see somebody locally, there's a way to find somebody. The good thing is that many of them can do telehealth, like I mentioned. So you could be referred to a genetic counselor by a doctor to discuss family history or genetic risks. When genetic counselors are we are not medical doctors. We are important parts of the healthcare team, right? So we talk about genetic risks for you and family. If we're seeing somebody who has a family history of cancer, we talk about that as well. So there's many different things that we can talk about, but the most important thing is to think of us as being part of your team to help you primarily with the genetics. So just for information, how does someone become a genetic counselor? Because it was actually something that Sherry and I talked about. And so the first step is that all genetic counselors have some sort of undergraduate or bachelor's degree. So typically that's in biology or other classical science or social science. My undergraduate degree is actually in psychology from Mizzou. They often have some other relevant work, whether that's volunteering, working in a research or clinical lab, or even shadowing genetic counselors. They apply for genetic counseling school, and there are approximately 50 programs around the country now. And so many of them are pretty small. Our class, we just increased our class times from 4 to 6 students a year. So we're pretty small. But part of that is because we need more genetic counselors, but as part of the master's degree training, you actually have to work in clinics. So I have students with me quite a lot and when I'm seeing patients. And so if I didn't have enough people for my students to train with, I just can't train as many people. So they go into a master's degree after being admitted. There's actually, I don't even know the number of students that are admitted anymore. It's over 400 to 500 maybe a year across the country. So we get coursework, we have clinical training. They see patients with me in clinic in the ALS center. Sometimes they see patients by telehealth or in person. And like I said, there are about 50 programs. They also have to do a research project. And then the final step is after finally graduating, they then take a board exam. So one thing you may have noticed on my first slide is my name. It had the letters CGC after that. That actually means that I'm a certified genetic counselor. That's how you know. So that's my certification. And then depending on where people live, you may need state licensure. And that's what I was explaining, but that's why I can only see patients in certain states because of the state licensure laws. So it's actually in the world of medical care, a relatively new specialty. So in 1971, the first graduate program started at Sarah Lawrence in New York. That's actually still a program that exists today. It's one of the largest. They had many meetings in the 70s and in the early, or even into the 80s, talking about how to make sure that people were getting the minimum requirements they need in order to help patients and families the best. And so the National Society of Genetic Counselors was created as a way for genetic counselors from around the country to kind of meet each other. So I'm certified by the American Board of Genetic Counseling. I was certified after I graduated in the early 2000s. But some genetic counselors going back to 1980 were actually certified and took the exact same test as a medical geneticist or a doctor. And now we have accreditation of programs. We have ABGC now does certification of genetic counselors and recertification. So if you're ever curious if somebody who you're seeing is a genetic counselor or not, you can actually look them up on this website and kind of see if they've had that minimum training. So what do we do, right? So our job is to provide information about genetics, inheritance, excuse me, and specific genetic conditions. So if I'm seeing somebody with a known family history of SOD1 ALS, for example, my job is to provide them with information about the genetics, as well as talk a little bit about the specifics about SOD1. That's very different than if I'm seeing somebody who doesn't yet have a genetic diagnosis and I'm talking more broadly about the genetic conditions. I talk about the benefits, risks, and limitations of genetic testing. Genetic testing is not 100%. If any of you or your family members have undergone genetic testing, you may know that already. I help interpret genetic testing results with families and kind of help them make decisions about results. If I'm seeing somebody who is not an established patient of the ALS Center and they test positive for one of these inherited ALS conditions, I then make sure that they're connected with the ALS Center at WashU. That's part of what I do as well. And my job really is to provide support to patients, to your family members, to other healthcare providers, and in the community as well. Obviously, here I am talking at the ALS Association meeting. But I also give talks to other healthcare providers about the importance of genetic testing. At the ALS Center at WashU, we have fellows, which are medical trainees after they've finished medical school and residency that are training to be providers who specialize in care of people with ALS and other neuromuscular conditions. And I give them lectures as well so that they understand better how to talk to their own patients about the genetic conditions. And like most, sorry, I just got an alert that said a closed captioning was started. So I had to, it like jumped up on my screen. Sorry about that. So like I kind of mentioned earlier, there are many different specialty areas. All genetic counselors have the same basic training, but what we often do after we graduate is get jobs in an area that we find the most interesting. I always love general genetics and adult neurological conditions. I've been seeing them for close to my entire career. But as a student, I went into school thinking I would love seeing prenatal patients. I did not. So I've kind of changed what I wanted to do as I graduated. And I did general and adult and pediatrics. I also did some work for a little bit with metabolic disease here in the state of Missouri doing newborn screening. Obviously, things like ALS are not on newborn screening, but there are other neurological conditions. And many genetic counselors also see patients with a personal or family history of cancer. And so that's a very large specialty area in our what we do, I guess. Here at WashU, the largest group of genetic counselors are in our group. And then we have some genetic counselors who work in other divisions, like working for the OB office and working in the infertility clinic. But other hospitals are very different. Maybe they have many different genetic counselors in different departments. And so it may not always look the same as what I'm describing to you from my clinic as well. Also, NSGC, National Genetic Counselors, loves infographics. So I took some of their lovely infographics, and this is one of them as well. So now to the kind of what I wanted to talk more about, which is actually what is genetic counseling? What is it like coming to see me, right? So this is when I was trying to figure out the best definition of genetic counseling. Actually, the CDC has a really good one, right? We collect your personal and family health history. We give you information to determine how likely it is that you or a family member could have a condition. And we can talk to you about and help you decide about whether or not a genetic test is right for you or your relative. Again, that is different than if I'm already seeing somebody that has a genetic condition, right? So if I am seeing somebody in the ALS Center, like I said, using the example of SOD1 earlier, and I'm seeing them after their diagnosis, I would talk to them a little bit about what this means for them, but also what it could mean for family members. And so many times when I'm seeing a newly genetically diagnosed individual with ALS, sometimes their family members come to the visits and learn a little bit as well. And that's because genetics kind of affects everybody in the family, right? It's not just the person that's affected. It can really impact everybody in the family, just like an ALS diagnosis would as well. This has kind of an extra bit onto it, and knowing that there's a genetic cause. The National Society of Genetic Counselors put together a formal definition of genetic counseling. That is like what you would expect from many of these organizations. It's very regimented, but right, the goal is really to help people understand and adapt to the familial implications, the psychological implications, or just medically what it could mean to have a genetic condition in the family. And so I thought about, because I think to some people, going to a genetic counselor or getting genetic counseling seems very foreign. And so I wanted to kind of explain a little bit more about what would happen if you came and saw me in clinic. So the first thing I usually do is I get some records, whether that's getting the individual with ALS's diagnosis, or maybe asking the patient to get a copy of the genetic testing results from their family member. And then I obtain medical and family history. And I have a kind of a visual of what it looks like when I take a family history. But, for the most part, when I'm seeing people who have ALS, I don't have to get a lot of medical history. The neurologist that's really their important job. My job is to understand the diagnosis and help them with the genetic testing. When it comes to kind of providing education, I talk about how conditions are inherited. What are the risks for additional family members? Are there other management or prevention strategies that are available? Are there any screening, testing, or research options? And kind of the biggest one that people ask me about is I provide risk assessment. Based on your family history of SOD1 ALS, what is my actual chance of, one, inheriting this genetic condition, and two, actually having ALS? And that's sometimes harder to kind of tease out, because having a genetic condition or a genetic change that you inherited from a parent doesn't 100% mean that you're going to have ALS. It doesn't tell us when you're going to have ALS, and that's part of the hardest part. I don't do a lot of management and prevention discussions with patients with ALS. That's really the neurologist's job. But I do sometimes talk with patients about, the ones that maybe don't have a neurologist. Would you like to see one of our neurologists? Would you like to be set up locally with somebody? Things like that. And then counseling. So one of the cornerstones of genetic counseling is a term called non-directiveness. And so non-directiveness just means that my job is not to say you need or you have to do something. It's to talk you through the process and what this could mean for you and helping you make the decision that's best for you. And I think this is really what sets genetic counseling apart from other related medical specialties, is that if you tell me that you're not ready for genetic testing, I totally get that, and I'm okay. And you can come back to me later if you change your mind. But my job really is to help you understand as best as possible what that could be. And then also I try to provide some support. The term psychosocial just means providing you support and understanding, because it's a lot, right? You may already have a family member with ALS, and now we're talking about what this could mean for you. And thinking through what that could be long-term is really difficult. Now, there are some areas where I'm a little bit more directive. So when I used to do newborn screening, I would say, we need your child to come in and get this testing done. It's very important for their health. It's a very different discussion versus somebody with ALS. And I also do a little bit of care coordination and follow-up. So sometimes I serve as a patient advocate, helping them get connected with things like the ALS Association or similar. I make referrals, right? I set them up with a neurology group here. I actually just did that today. I sent somebody over to the ALS Center here at WashU with a new diagnosis because this individual was tested due to a family history. I help coordinate care for at-risk family members. So in genetics, it's never just a single person that sees me. I sometimes see multiple siblings or aunts and uncles or cousins, and trying to help them best understand and get testing if that's what they want. One of the big things I do is really explaining the test results and calling them out. If it's something we talked a lot about, we hopefully don't need to have a super long discussion, but I also sometimes meet with people and follow up to talk about results as well. I really find that I am most useful in supporting families and individuals through the process of finding resources and getting connected with other individuals. Sometimes I get questions about what treatment options are available, and I defer those to a neurologist because that's really their specialty. but my job really is to help as much as possible. Now, I was gonna say I stole this, but my student who just graduated in May made this beautiful family history from the movie Encanto, if anybody's ever seen that. So this is kind of a family history. And I like this visual because for those who have kids or grandkids, most of them have seen this movie. So you have the grandma and the dad, can't remember his name right now. Then you have the three siblings. They're technically, actually I need to fix this because they're triplets, but I think she struggled with getting it to view, but essentially, right, you see three children, you see the ones that have future children, and it kind of shows you this is what I'm taking. Now, if I took this family history from Encanto and I made it look like when I draw it, this is what it looks like, right? This is what I'm taking a family history of in clinic. It's the same family, right? We have mom, dad, the three triplets, all the kids. And then this is what it looks like if I'm drawing it and I'm saving it as your visit. So this is what a family history, or what we refer to as a pedigree, looks like. So when I'm meeting families, I'm often asking about additional family members. I'm asking about their presentation, what sort of medical problems they had. If you were taking the Encanto family history, you'd ask about their powers, right? I have a 7-year-old who loves this movie, so I've seen this enough times to know all the music, but that's kind of what this is showing you, is it's taking your actual family and putting it into a more easily digestible and visual way to understand better how things present. Now, there are a lot of kind of unique things about taking family histories. You can kind of see here on the left where you have the two girls with like an upside down V. That's actually how you designate twins. If we were to draw this one correctly, they're actually triplets. You'd have 3 coming off a single dot. I'm gonna have to fix that for next time. I didn't notice it until I was talking. And then we have adoption as well, right? So knowing if somebody had a child that they then adopted out, if somebody's been adopted by a family member, or even if, sometimes I talk to people and they mention their children and they're like, oh, actually one of them is adopted. It's important for me to note that for genetic risk as well. So that's what this little bracket means, is that this person's been adopted. My student's name is Paige. She also did one for, trying to remember what the other one was, like The Simpsons or something. I don't know how she had time to do that while she was a student, but it was good. And then we have what pregnancies look like. And then if someone has passed away, and this I think can be a little bit jarring if you've never seen it before. Oftentimes when I'm taking family histories, I make a slash through somebody. It just means that they've passed away. And that's my way of knowing that they've passed. I also designate how old they were when they died, what the cause of their death was, and things like that. If you haven't seen Encanto, I highly recommend it. Even if you're an adult, it's very cute. Yeah. As a side note, when I was working in Boston, I used to work for a Down syndrome clinic. And I had a mom tell me, because I hadn't seen the movie Frozen yet, that I had to watch Frozen, because how would I know how to talk to my patients? And I actually started watching Disney movies before I had kids because of that, because it allowed me to talk to people, which isn't that important, but Encanto is one of those movies I think that's very popular. So what I was going to do is talk a little bit about some important things that I think that I discuss with patients as it pertains to their genetic information, because sometimes this is why someone is afraid or are concerned about getting genetic testing. So you may have all heard about HIPAA. It's the Health Insurance Portability and Accountability Act. It was passed in the 1990s. It prohibits the use of health information as a basis for denying or limiting coverage. So that actually existed way before the Affordable Care Act or the other law I'm going to talk about. It did limit pre-existing conclusions, but they were still allowed. And then genetic information in the absence of a current illness should not be considered a pre-existing condition. Now, HIPAA has a lot of other things. It talks about protecting your health information as well. I'm just talking specifically about genetics. Then we have the Affordable Care Act, or the ACA, that was passed in, I forgot to write the numbers, like 2012, maybe 2014. Can't remember. What it did is it provided access to health insurance for all Americans. It eliminated pre-existing conditions in that you couldn't be denied health insurance. That is probably one of the most popular parts of this law. So if an individual who is now in a clinical trial, since I was talking about clinical trials, and there is a family history or the known history of ALS, for example, you can't be denied health insurance. That's what this means. And you can't also cancel policies. Now, I'm very direct with my patients and say, Obviously, laws can be changed. We've seen changes to this law even in the short time since it was passed. And so it's hard to know what the impact will be in the near future. But I do find it very important to at least mention that this exists. It doesn't specifically talk about genetics. Like, what does it mean to have a genetics? And part of that is because of this law that most people are not as familiar with. So this is from 2008. It's called the Genetic Information Non-Discrimination Act, or GINA. What it does is it prohibits the use of genetic information in setting eligibility, coverage, premiums for groups or individual health plans. It also prohibits the use of genetic information in hiring, promotions, privileges, compensation, termination. So you can't be fired or denied promotion based on the presence of a genetic condition, genetic predisposition, or genetic condition in you or a family member. It also covers genetic info of an individual, a family, including fetuses and legally held embryos, which is not as important for us, but it's important to note. So what that means is that any genetic information, whether it's a family history, research participation, genetic testing results, the fact that you've had genetic counseling, they're covered by this law. It does not address or cover life insurance, disability, or long-term care insurance. So when I'm talking with individuals before doing genetic testing, maybe they have a family history of SOD1 ALS, for example, I mentioned this specifically. And I think for individuals with ALS, long-term care insurance is very important if possible. And so that's why I bring that up. I also talk about life insurance. It excludes small employers. I think it's less than 15 people, anybody in the military or government workers. This is a little handout that I provide to people. You can actually find it online. It's called GINA and You. It talks about just briefly what the bill does or does not cover. And it was put together by a couple different organizations, Genetic Alliance being one of them. They are an organization that exists for family members and patients who have genetic conditions. And it was also put together by some national, like NCH, it's like national, I can't read the acronym from here, but you can kind of see a little bit online. If this is something you want to get your hands on, you can't find it, you can also email Sherry and I can send it to her as well. So I think important part of my job is to provide this sort of information to patients and families to either help them understand or release some of the anxiety that they may have just based on things that they read online, right? When I started doing genetic counseling, Facebook didn't really exist, right? There weren't as many organizations as they are now for families. And then the last thing I wanted to mention was something called the 21st Century Cures Act. I'm not going to go for this is kind of a newer thing that was passed. It was signed in 2016 and implemented in 2020, although some of the things have been coming on. The biggest thing I wanted to mention is that there is information. So one is that the rule supports patient access to electronic medical information, and it has to be very secure, right? So that's what that middle little image means. On the left, what that means is that, patients have control of their medical record. So for me, I find it very important to make sure that my patients have access to their test results. So I mention this because you have a right as a patient, as well as a family member, a surviving family member, or you can also talk to your parents to get copies of their genetic testing results if that's something that you want. It's a little bit more difficult if somebody has died and they have genetic testing results somewhere, but there are laws that allow you access to those. And so I just make a point to mention that if you happen to have genetic testing or counseling, I'm always very good at making sure that my patients get a copy of their test results so they can provide them to the family members. But that I just want to mention it's your right to have access to your genetic testing results. And so I just wanted to mention that too. It's funny is that somebody that I work with always calls it the CARES Act. And I don't know why that is. I think it's because the Affordable Care Act, I think it's just a lot of A's, but it's called the 21st Century Cures Act. So you do have access to your medical records. And then just for completeness, the little picture on the right says that you're allowed to shop for care and manage costs. And that's also why I give patients, when I can't give them testing at no charge, I'm very upfront about what the cost would be. So the last section I want to say is just genetic testing for ALS, in case that's something that you're interested in or your family members have had. So why do people do this? right? So genetic testing for ALS can provide some information about prognosis. There is knowledge out there about different genetic forms of ALS progressing at different rates. There are also information about some genetic forms of ALS having additional risk for other neurological complications, and that's very rare, but it's something important to know. There are clinical trials available for ALS, and many now require genetic testing. Sometimes genetic testing isn't provided as part of the clinical trial. We do that as part of the tofersen clinical trial with Biogen. And now there are current treatments available for specific genetic causes of ALS, including tofersen that I mentioned before, which is for SOD1 ALS. So having genetic testing results can be important. I'm using a lot of pictures in the next slides, and I'll try to orient you to those as much as possible. So this is actually a picture that I can use with patients. So if you remember back to biology, you have your cell, right? And in your cell is your nucleus, which holds your DNA. And the packages of genetic information that we get from our parents are called chromosomes. So we get our DNA from our parents, and these chromosomes are these really tightly packed pieces of DNA. We then can look at our chromosomes and look at our DNA specifically. So if you think of DNA like a large book, chromosomes are like chapters, and genes would be like a sentence in your book. So genetic testing, what it does is it looks at these specific genes or these specific sentences, looking for letter changes, missing or extra pieces of information that would cause the gene to work incorrectly. And the final step in the process is that genes make proteins that travel throughout our body and do the work. And so sometimes when we do genetic testing, the answer is very clear. We found a genetic change. We know that it causes the gene to work wrong and the protein doesn't work correctly. And that's how we are able to confirm that it causes ALS. So that's my little brief discussion, because I think it's important to have a better idea of what I'm talking about. So in ALS, about 10% of ALS are familial. So some common familial causes include C9orf72. You can see it there in the yellow giant circle. That's the most common genetic cause of ALS. The second one would be SOD1, which is about 20 to 25%. After that, we get into, we're taking everybody with ALS, we're taking 10% of ALS, and we're getting into very, very small percentages of people that have any of these genes that you can see here that can cause ALS. Now, some of these genes, such as C9orf72 or VCP, can also cause other neurological conditions in some family members, but that's part of the discussion that we have. So you can kind of see that in the early 90s, they discovered SOD1, and then there was a pretty big gap of almost 10 years before they started really identifying these genes that cause ALS. When they found C9orf72, it was just like, it was amazing, right? All of a sudden we found the largest kind of cause of ALS. And I would say that's probably the gene that I see most often in clinic, right? So when we do genetic testing for ALS, one of the things that we offer and kind of needing to know is, how do we choose what to test you for? So if it's a new diagnosis of ALS, we're often looking at a handful, 20, 30 different genes that includes these genes that are listed on here, rather than going one at a time. And that's for both for cost and also time. It would take a long time if you did each of these at a single time. Now, if somebody comes in with a family history of C9orf72, for example, I'm not going to test them for everything else. It's not necessary. We focus just on the C9orf72. So that's why making sure that you're getting the right testing is also important, and that you're getting covered what needs to be covered. So most genetic forms of ALS are what we call autosomal dominant. I would say the vast, vast majority, although there's some rare cases that are a little bit different. But autosomal dominant just means that when somebody is affected, there is a 50% chance they would have a child with the condition. And that's what this looks like here. So we have both a visual of an affected mother, someone with ALS, or affected father. And you can see it doesn't matter if they have a son or a daughter, there's always that 50% risk that their children can have the condition. And I think, it's easy for me to say 50%. I say it all the time, but to some people that's really high. Right. And so that's often what I'm talking to people about as well. Now, if I know there's a family history of ALS, of a genetic form of ALS, let's say C9orf72, that's it's the autosomal dominant, I talk with somebody and I can get a clear, yes, you do have it, or no, you don't have it. And that's what my next slide is showing, is what are the type of results. So we can get a normal result. So that means that they didn't find any genetic changes. They can get an abnormal result, meaning they found a known genetic form. That's very easy when you have a family history. It's either yes or no. It's a little bit harder when sometimes we get individuals who have ALS, and maybe we get these kind of in-between variants of uncertain significance. So these are genetic changes that we know are present, but based on our knowledge, whether it's the knowledge of the gene or the knowledge of this certain genetic change, I can't say with certainty that it would cause ALS. And that's a big part of what I discuss as well with individuals. In genetics, this is the potential result impact of the results, but these are the terms that we use. And you may have seen this before. Now, I'm using the term variant a lot. Probably like 5 years ago, we used to say mutation. It's the same thing. That's what it just means, different from typical or different from normal. And so in genetics, we have like most genetic things, most medical groups that have their own names for everything. It's the only way I can think about it. We use the term pathogenic to mean with essentially 99 to 100% certainty, we know that this genetic change can cause what we're looking for. We'll use it like ALS. We can get benign, which is where there's like practically a 0% chance that it would cause a medical issue. It's just kind of a normal variant. We all have genetic changes. And then we have these likely categories. That's more like 90 to 95%. And then you can see in the middle is that big chunk, which tells us that there's a variant there, but we're not sure. And so sometimes when I see patients and I get a VUS or a variant of uncertain significance, maybe in 5 or 10 years, we have more information and we get more families or more individuals and we can kind of push it in one direction or the other. This is part of discussion. It can be a little bit nuanced and I think can be hard, even for people who are familiar with genetics. It's hard, right? You're telling me that there's a genetic change in my DNA, but you can't tell me if it's actually going to cause a problem. And the answer is yes. And that's very difficult as well. Some of the more expansive or extensive genetic testing that's available is something called whole genome or whole exome. So using that analogy, like I said earlier, of genes like sentences, they're made up of what we call exons and introns. So the exon is a part of our DNA that actually makes the protein. And the intron is part of our DNA that is more regulatory. It doesn't make the protein. So we sometimes, especially in individuals where there's a large family history and that kind of first line testing, I'm going to go back to this slide, that let's say we've tested all of these well-known, well-described genes, but there's still a family history and we can't figure out what it is. Then we offer this sort of more extensive testing. So I send whole exome sequencing primarily on most of my patients. Sometimes I can do genome. There's the limitations with insurance. There's limitations on cost, and it's just insurance by insurance dependent. The reason why we do this sort of testing is it's kind of the most extensive testing that looks at your entire DNA. However, like I mentioned, we tend to start with that kind of more basic genetic testing panel because it's so much more likely to find something. So these may be things that you have seen or you have heard of. They are not done routinely on patients with ALS. We don't do them on every patient that we see, but they're there as kind of more of a next step test if we're still concerned or we haven't found out an answer. My last kind of visual slide is, if you want to see a genetic counselor, we would be more than happy to see you. There's a website called aboutgeneticcounselors.com. It's been created by our National Society of Genetic Counselors. There's actually a Find a Genetic Counselor link. So you can click there and use your location, whether or not someone does telehealth, whether or not they're in person, what state they're in. You can look for a genetic counselor that is registered with this website. So if you look for me, you could find me. You can also read more about genetic counselors, who we are, why we would see them, things that you may need to be prepared when you go see them. And there's also information about becoming a genetic counselor, if anybody knows somebody that wants to be a genetic counselor. But that's their website. It's aboutgeneticcounselors.com. And this is my references more for Sherry so she can see if she had a question. But this is kind of my last slide. So this is my contact information. This is my clinic number. if you happen to call me, it's going to be pediatrics. And I guess I explained it to Sherry and I explained it to you. It's actually very difficult to find adult genetics. So we see both kids and adults, even though we're based in pediatrics. So I just wanted to give you, anybody that has a question or concern, or if Sherry has questions, I'm happy to answer them as well.
Well, thank you so much, Tomi. That was, I learned some new things I didn't know. I invite people again. I don't see any questions in the chat or the question and answer. I have a couple questions that I took away I want to ask, but if anybody on the call has other questions, specific questions they want to know, just go ahead and put them in the chat or the Q&A section, and I'll watch for those. So the couple things that I thought up were that, is there any reason for a family member of someone that's been diagnosed with ALS, but the person with ALS was tested and was not found to have any of those genes? Is there any reason for a family member of that person to go for testing?
That's actually a good question. I see patients like this all the time, where their adult relative, their parent, primarily, sometimes grandparent, had a diagnosis of ALS and they either weren't tested or they were tested 5-10 years ago. We are often finding new genetic causes of ALS and other genetic conditions. So if you know that you had a relative that was tested 10 years ago. So I'm going to slide back a couple slides if I can get it. There you go. So 10 years ago, 2014, right? Maybe they were tested for all of these, but many of these that were discovered were more on a research basis. And so it's possible that if they were diagnosed in the early 2000s, they may never have been tested for this C9orf72, which again causes 40 to 50%. So sometimes if someone can get a hold of their relative's test result, I meet with them, I can often look at it and see if there's something that's been missing or hasn't been tested. But if it was only a few years ago, that's a little bit different, because it's possible that they already had a lot of testing and it's just not genetic, right?
Okay.
I'm talking about that small subset of families who have familial ALS, but there's unfortunately so many other families where we don't always know why. And
Right.
that makes it much harder.
Okay. Okay. Well, that's helpful. So if it is somebody that has been in their family history a long time ago, then it might be worth looking at that if they're interested in pursuing that.
And I have found genetic causes of ALS in family members of people who have never been tested that maybe died 20 years ago. So it does.
Okay. So especially with a longer history of it, probably if you're interested in knowing would be beneficial.
Yes. If you're interested in knowing, that's a good question. That's a good point.
Yeah. Talk a little bit to that, which I know if you're counseling somebody before they're getting their test, which is that the standard that they're counseled, a family member would be counseled before they get a test?
That is that would hopefully be the standard, but it's not always done that way. If someone were to approach a primary care doctor or a neurologist, maybe they would do it and they would meet with a genetic counselor first. In our clinic, that's kind of how we're set up, is that if they diagnose somebody, but a relative wants testing, they send them to me, given the nuance of the discussion. But you mentioned, what if they don't want testing? I still meet with people. I met with somebody for a different neurological condition last year who waited 6 months and then called me and said, I'm ready for the testing, right? And that's okay as well. You can also just put all this information in your back pocket and come at it again in 3 to 5 years, 10 years, it doesn't matter, just whatever works for you. Because, one thing I didn't fully mention is that we really don't recommend testing kids for these sort of genetic conditions. And so sometimes parents wait until their kids are older to have the testing done as well.
Okay. Okay. And can you speak a little bit about why it really kind of is important for a family member in particular to talk to a genetic counselor if possible before they decide? What are some of those nuances of why that might be important, other than just, here's a test, go take this test?
Yeah. One of the things I like to mention is really thinking through what this could mean, right? If your parent has C9orf72 and you get testing done but you don't know necessarily what it means. And then all of a sudden you're hit with this information that you were unaware of. Like that's a very big shock.
Mhm.
Also if you have an adult family member who is not sure and then they get testing and then they really wish they would have said no, right? And they wish they would have known to get life insurance or known to get long-term care insurance beforehand. I think all of that is definitely are things to think about. I just think it's sometimes helpful to talk with somebody who has your best interests in mind, right? Like I used that term non-directive earlier. My best interests are whatever your best interests are.
Mhm.
I'm not there to tell you to do the testing because it's important for your health, which it might be. But if you're not ready, you're not ready. And that's okay as well. It
Mhm.
doesn't mean that you have to do the testing.
Okay. And one question came up, what would be the best age for family members to get tested? Is
That
there
is,
such a thing?
I don't know if there is such a thing. I have tested people as young as like 19 or 20 for neurological conditions. I have tested people who wait until their kids are older, maybe they're in their late 40s. It's whatever age you feel like you're ready. Um, Sometimes parents will be like, I don't think my 22-year-old is ready for this, right? And my big thing is, well, how would they know if if they didn't know that it was even an option? Maybe they would have more questions. And so I just feel like it's important for family members to give as much information as they can to those family members and help them make the best decision for themselves.
Mhm.
I also feel like patients in general, right, they worry about their family, right? So someone in their 60s with a new diagnosis of ALS is now worried about their kids and their grandkids. Um, and I usually tell them as well, like your kids may not feel the same way as you, and that's okay as well.
Mhm.
Right? They're dealing
Mhm.
with your diagnosis separately from this new genetic diagnosis.
Sure.
I'm a big proponent of um, providing honesty and information to people and letting them make the decision themselves. That's kind of my recommendation.
You're getting lots of little hearts coming up
I know I
for
said,
that
"Dude, I've never seen
non-directive,
that.
and
I've never
that's
seen that
good for
before."
them.
Yeah, they're popping up in the bottom of my screen. I didn't know that.
Yeah, yeah. So that is a first for our speakers. So that's wonderful. But they definitely responding to, the non-directive and that's doing what's best for them, because it's really not definitive, right? If they get one of those genes and that's what their parent or relative had, that doesn't absolutely mean they're going to get ALS. Is that
I would
correct?
that that is yes. Sorry, I'm thinking quickly through the genes in my head. There are some genes that have a higher risk than others
Okay.
as well. Um, there are some that are age dependent, right? If people are going to have symptoms, they usually have symptoms by the time they're 60 or 70 or 80. But I think it's hard to say with 100% certainty that someone would never get symptoms. I just can't predict when and how they're going to present. They may not present like their parents, right? And some individuals with ALS present um, with like trying to give it like sometimes I've had people that present first with like kind of issues with swallowing and choking, like that
Mm,
sort of thing, versus like lower motor neuron issues.
sure.
So I can't always predict that specifically, but I can at least give you some information on what to expect and then make sure that you're connected with people who are ready to help you if and when you do show symptoms.
Okay. Another one that I've come across is, what if there's several family members and, one or a few of them really want the testing and the other ones don't? What are the implications with that? I mean, even for the ones who didn't get testing, but if they're aware of their
Mhm.
family history and they've had siblings tested, can that create problems for them getting life insurance and long-term care?
Well, my biggest thing about life insurance and long-term care insurance is that you can pretty much be denied for those for any reason that the insurance wants you to. So it's
Mhm.
very hard to predict. Having a family history, like if anybody's I've applied for life insurance privately. So, I have to answer all the questions, any family history, and then they give you that long list of things, right? And
Right.
so, um, having a relative with ALS is something that you would have to disclose anyway. So, but I think it's really insurance and person dependent because like I said, long-term care insurance is usually more of like a cost issue, right? They may charge more than other people versus life insurance, you would probably be denied for or charged a lot more.
Okay.
For example, I had breast cancer and I happened to apply for life insurance 3 months before I was diagnosed with breast cancer. It was just a very random thing, right? If I
Right.
had tried afterwards, I would have had a very different experience. And that's hard to predict. They asked me a bunch of questions and now they're stuck with me as one of their clients, right? So it doesn't matter
Yeah.
anyway.
Okay. And then lastly, can you speak a little bit to the kind of cost that are involved for people and, does insurance ever cover or what is the cost?
So I'm going to talk specifically about the ALS genes, those ones that I showed on the slide in the little bubbles. Currently, there are some sponsored testing, meaning there is free testing available for people with ALS and people with a family history of ALS. I think there's at least one company I know that's offering it right now. It's done through a good lab and you send it off and it's at no charge. There are things sometimes if you don't fit those criteria for the sponsored testing or you go for the larger exome sequencing, it's really insurance dependent what the cost could be. Most of the time, if you have a family history of ALS, if you're able to get the free testing, great, right? You don't have to pay for it. Many insurances or many labs offer like self-pay options anywhere between $100 to like $250. So,
Okay.
but as for the genetic counseling itself, I'm a lot cheaper than a doctor if your insurance doesn't cover it, but it's really insurance dependent as well.
Okay. Okay. So, well, I don't see any more questions coming up. So I think that we've pretty much covered it. And I really appreciate you being here today, Tomi, and covering this topic for us. For those that are here, I will send out a follow-up email with our recording of this presentation yet this week, and we'll have some other resources. And I wrote down as you went through some of those other ones, I'll try to include those in that email as well. And then just a reminder, next month, our next month topic is we're going to be really having a conversation with an estate planning lawyer to really talk about why there's elements of that everyone needs to be aware of. And it'll be very conversational and time for asking questions where that one won't be recorded for distribution. We'll try to summarize stuff a lot, but because we want you to be able to interact with that attorney if possible. So thank you again, Tomi, and thank everyone for filling out the survey when they leave this the presentation today.
Thank you very much.
All right, have a good day.